Today I'll be talking on practical prescription of the feeds, where I would cover what is the nutrition diagnosis and the prescription, the nutrition assessment of the patient. I won't go into detail because that has been already covered. Recognizing the nutritional requirements, again a bit of it, understanding the prognosis and accordingly taking the correct action, and planning of the feeds, delivery of the feeds, and obviously reassessment. So nutrition diagnosis is basically an extremely critical step in nutrition care process where we understand a PES statement. Now, what is PES? It is one patient specific to one problem that stands for P, one etiology, and based on assessment of signs and symptoms, that is S. So basically it has been designed by ADA, still the research is going on, but this actually helps a lot. For example, if an underweight patient admitted in the hospital, that is a problem. P, related to continued reduced intake of regular meals, that is etiology, resulting in less than 500 calories less than RDA or 30 grams proteins less than RDA, as per the evidenced by a BMI which is around 20, which is a sign and symptom. So once we arrive at the nutrition diagnosis, we have to, as a dietitian, we have to go ahead with the nutritional prescription. So prescription, basically a diet, a general diet where we have to take into consideration different nutrients, that is protein, macro and micronutrients, which are required for the optimal growth and tissue repair. But a therapeutic diet, where a diet intervention, which is ordered by a healthcare practitioner, a nephrologist, as part of the treatment for clinical condition where the patient's nutritional status is altered, and there is a decrease or increase in certain substances, like we have to make sure that we have to give low sodium or low potassium, sometimes high potassium, sometimes high protein, high calories, something like that. So when we talk about therapeutic diet, so we arrive at the conclusion that the patient's nutritional status is A, B, C. Mostly it is either B or C. Then we arrive at the prescription part. But before that, when from the nutritional assessment point of view, we have to understand how critical it is to intervene the patient nutritionally on day 1 within 24 hours of the patient's admission. In critical area, it is within 6 hours of the admission, provided it is not in the night. So putting everything into the practice is basically a comprehensive and routine assessment, which as per the NABH requirement happens within 6 to maximum 24 hours in the general wards, and where according to the National Kidney Foundation, this is about the patients who are hospitalized, where we take care of the assessment during this particular period. But for the patients who are regularly on dialysis, coming to the AKD, we have to make sure that, and we have started that in our hospital, the dietitian does go for the round, alternate day, covering all the 3 shifts of the dialysis patients, where the continuous reassessment of the patient is required, because malnutrition can lead to a poor prognosis. So I won't go into this. How is nutritional health checked? Okay. Now, when we arrive at what diet has to be prescribed, where there are so many restrictions on the pre-dialysis patients, there are increased requirements during the dialysis, phosphorus restriction, potassium fluid, sodium restriction, limited selection of the fruits and vegetables, appetite is low. We have to look for the fiber and the micronutrients. So actually, what is left to eat is a big question mark. So nutritional therapy induces favorable metabolic changes, which prevents the signs and symptoms of renal insufficiency, where a stepwise approach or a simplified diet regimens usually are prescribed while taking into consideration not only the renal functioning of the patient, but the progression rate, the economic, psychological, and functional aspects also are something which are to be considered. Right selection of the formula feeds, and in order to allow efficacy and safety, the importance of monitoring, that is reassessment, is something which is required. Where the patients are on oral feed, where we have to understand, we have to make patient understand how much fluid is required. We can give them the goal that this is the dry weight goal, how much water is allowed, how much fluid is going in the IV, and accordingly we can specify it. Apart from that, if suppose patient is consuming say a mug of coffee in the morning as his breakfast portion, we can advise them, instead of having this, what can be replaced by a mug of coffee, so that we can take care of the intake of the concentration of the proteins and calories, and we can take care of the fluid requirement. So I can give you certain examples, like suppose a patient is on the oral, what prescription we consider in hospital is basically understanding the nutri shots, like a combination of some medical scientific formula which can be combined with little amount of fluid, which can be given as a filler. We can understand some millet lentil laddus kind of thing. If the potassium is under control and patient's appetite is less, we also do give 1 or 2 pieces of apple, so that if the taste gets changed. If abdominal bloating is there, we can think about some ajwain, hing or soft decoction that we do in our hospital. We have to prevent constipation, so understanding soluble fiber which can be mixed with the food, so no water is required. Addition of MCTs for the calories, taste enhancers like lemon, ginger, black salt kind of thing. In case of RT feeds, the initiation, we have to make sure the golden hour, like as soon as the patient gets admitted, we have to understand how critical it is to have the nutritional intervention done. We can start with the scientific formula and can be followed with a combination of kitchen as well as scientific formula. And the most important thing, which madam also will agree with me, that involving relatives and motivational counseling of the patient is something which is the most important part of the nutrition prescription. Sometimes we do face the problems like suddenly the scientific formula which has been advised is discontinued by the consultant in our hospital. Does not happen normally, where we can directly discuss, the consultant and the dietitian can have the direct discussion and understand if at all there are prolonged hours of NBM, we can start the night feeding, or if at all anything has to be, if the patient is having some GI disturbances, what else better can be done for the patient, so that can be, we can arrive at the conclusion after the discussion. So purpose and scope is basically to understand that 80% of calories and other nutrient target can be achieved within the 24 hours. So first is a consultation, understanding from the consultant, open discussion, diet modification for the patient, assessment of the patient, progress notes where we have to be specific in writing in the file that how much exact water intake the patient is taking, fluid intake in terms of water, the fluid going through the diet and the fluid going through the IV. So these specifications we have advised, suppose 1800 calories per day, but actual intake of the patient is maybe around 1000 calories or maybe 800 calories if the patient is on oral feed. If on RT feed, we are able to achieve the 100% RDA. So all those points have to be regularly documented, discussed, modified, assessed, reassessed, and then obviously at the time of discharge, the patient should be that what we call as road to recovery in our hospital, where even post discharge, the patient's nutritional status has to be either maintained or improvised. Definitely, if scope is there, we can definitely improvise. But even post discharge, or the patient continues to come in the dialysis unit, then we have to make sure that nutritionally we are giving 360-degree care to the patients. So the suggestion is dietitians must in the patient care team to achieve the desired daily energy protein targets, not only the macro but also the micronutrient targets. Maintaining and or improving the patient's nutritional status is at most important. In fact, we have started doing the graphical system where on a day one, patient's nutritional or the patient's nutritional status is here, and at the time of discharge, where does patient reach? Also, in terms of the nutritional content, like today, 20% of RDA is achieved. Today was 0. Maybe patient was NBM for whatever XYZ reason. Today we could achieve 100%. So that graphical presentation immediately at a glance gives us the understanding where do we stand. It is a first understanding for us that where do we stand and where we have to take the proper action. Also, when the consultant goes through the notes, it is a clear-cut understanding. Okay, we are arriving here. We, if at all any suggestions are there, we can have the open discussion kind of thing. So prescription is one part, but the documentation, which is extremely important, and the practical implementation. So all those things, if at all happens with a wonderful communication with the consultants, we are very lucky to have wonderful team of nephrologists in our hospital, Dr. Ankit Modi, Madam Zupe. So it's like a uric acid is very high, just do the needful. It doesn't need it's absolutely practical approach, and it is in favor of the patient's benefit. And what is the dietitian's role? It is basically detection, which is extremely important, detection of aggressive nutrition support at early stage with the aim to prevent refeeding or overfeeding, malnutrition, and thus aiding in reducing the overall ICU as well as the hospital stay. Thank you so much.